Okay, it's been a couple of minutes, so I'm going to go ahead and get started in the interest of time. Hi everyone, welcome to DFA's March Advocacy Grand Rounds. This is entitled Family Planning in the LGBTQ plus community. My name's Jackie. I am the lead of the Sexual and Gender Health Subcommittee at Doctors for America, and I'll be moderating today. Before we get started, I wanted to take a quick minute to invite you to officially join Doctors for America. Being a DFA member today means making the important and simple step of selecting a membership level and paying your annual membership dues to support DFA's organizational sustainability and incredible programs like this Advocacy Grand Round series. There are 4 different levels to choose from, and then Raya, our DFA admin, will put the link to join in the chat, and we'll be making a recording and all materials available afterwards. A few quick ground rules for this educational session. 1, there's no such thing as a stupid question. And 2, speaking of questions, please remember to use the Q&A feature. We will address your questions during the second half of our session. And also look out for comments in the chat. DFA staff will be sharing helpful links during the session. Now on to our lovely speaker. I am thrilled to welcome Dr. Paula Amato. She is a double board certified OBGYN and reproductive endocrinologist with a career focused on women's health. Dr. Amato is a professor of obstetrics and gynecology and director of the Division of Reproductive Endocrinology and Infertility at Oregon Health and Science University. Dr. Amato served as president of the American Society for Reproductive Medicine from 2023 to 2024, and her clinical and research interests include infertility, LGBTQ family building and transgender care, menopause, PCOS, and third-party reproduction. Today, Dr. Amato will be providing us an overview of available clinical services for LGBTQ plus patients when it comes to family planning and how providers of all specialties can equip this information to serve their LGBTQ plus patients. She will also frame this discussion in the setting of current state and federal policies that shape how and when these patients can access family planning. So without further ado, I'll turn it over to Dr. Amato.
Thank you very much, Jackie, for that very kind introduction, and thank you to the organizers for inviting me. Thrilled to be here. I'm a member of DFA myself and love the organization and the work that you do, so I'm glad to be here. So as Jackie said, I just wanted to give sort of a general overview of LGBTQ family building, and wasn't entirely sure, who the audience would be, so it's kind of geared towards some of you. I would imagine most of you are healthcare providers. You might have LGBTQ patients in your practices that desire family building, or some of you may have a personal interest as well. So it'll be sort of general. And then, as Jackie said, we'll have questions at the end. We'll talk about the different family building options. This area of medicine is quite regulated because it involves often donor gametes, donor sperm, donor eggs, sometimes gestational carriers. So the FDA is involved. And as Jackie mentioned, I'm a member, former president, the ASRM, American Society for Reproductive Medicine. And that organization also issues practice guidelines, which most of us or all of us are supposed to be abiding by. And we'll spend a little bit of time as well talking about fertility preservation, specifically for transgender patients, but this also applies to, single people who want to preserve their fertility for future use. A little just comment about terminology. There's a variety of different terms that we use. There's a variety of different terms patients use as well. So it's kind of, sometimes I just ask patients what their preferred terms are for things. I mean, in general, to make a baby, you need eggs, you need sperm, and you need a uterus in general. But these are just some of the different terms that we use for the various anatomical parts involved, gametes, etc. One term that you may or may not be familiar with is co-IVF or co-maternity or reciprocal IVF. This is when you have like a same-sex female couple where they undergo in vitro fertilization and use the eggs of one or both partners, and then the other partner carries that embryo. So we call that co-IVF or reciprocal IVF. So just an example. And usually, because we're often dealing with donor gametes, we talk about the parents as the intended parents, or rather than the donor being the genetic parents. We don't need to we talk about donors and we talk about intended parents. So LGBT parenting, or LGBTQ, I should say, parenting is very common. This is data from the Williams Institute. It's probably an underestimate, but about 20 to 30% of LGBTQ adults are parents. Sometimes they have children within the context of a same-sex relationship, but often they have children from previous relationships, sometimes heterosexual relationships, sometimes they're single. This is still lower than the parenting prevalence for non-LGBTQ individuals, but it's quite common, is becoming more common, I would say, over time. And there's about 3 million LGBT adults in the US who are currently parenting minors, and about 15 million Americans that have an LGBTQ parent. So we'll start with fertility options for cisgender single women or female same-sex couples. Typically, so almost always, I would say, not always, but almost always, LGBTQ parenting does require assistance of some kind, medical assistance, and usually either donor gametes and or a gestational carrier. So for single women and same-sex female couple, they usually need donor sperm. The most common way single women and female same-sex couples conceive is usually through what we call donor insemination. So this is intrauterine insemination of donor sperm. And they may or may not be on fertility medication as well. Typically, if someone is young and they don't have any history of infertility, we don't always use fertility medications. But if they try a few cycles unmedicated and they're still not pregnant, or they're older, then sometimes we'll add fertility medications. And of course, some of these patients end up being infertile, right? They just don't know until they try, and some of them end up needing to do IVF or in vitro fertilization with their own eggs. We mentioned briefly co-IVF, reciprocal IVF. This is very common in situations where insurance covers it, because otherwise it can be very expensive. All these treatments, unfortunately, are expensive if you're having to pay out of pocket. But reciprocal IVF, or IVF in general, you're talking about $20,000 to $25,000 per cycle. So I think a lot of female same-sex couples would want to do co-IVF, but not all of them do, in large part because it can be very expensive if insurance doesn't cover it. And then embryo donation is also, I would say, like a relatively newer options that's less well known, but it's a really, really great option especially for single women or women who need to use donor eggs, and they're going to use donor sperm as well. And these are embryos that are donated from other patients, either single patients or couples who have undergone IVF for their own use to have a baby, but then they have maybe leftover embryos, and they have a few options of what to do with those embryos. They can certainly, keep them frozen indefinitely. They could discard them. They could donate them to research, and in some cases, they choose to donate them to another patient. So it's a really nice way to build a family, and it's particularly common, I would say, in amongst LGBTQ people. And then you can choose to have a relationship depending on the donor's wishes and your wishes as a recipient with the donor. And so the children, of course, would be full siblings, and then they can, get to know each other and that type of thing. And it's often less expensive than, doing something like autologous IVF or reciprocal IVF, because the embryos are already created. So the only cost is the embryo transfer, and then some administrative costs to kind of, for agencies to match a recipient and a donor. So if you have a same-sex couple, usually there's a question about who's going to carry the baby. Sometimes one person wants to carry and the other person has no interest in carrying, so that makes it kind of easy. Other considerations are like the age of each partner. So obviously, the younger the woman is, the more successful things like donors insemination and IVF are, because women, as you all know, are born with a finite number of eggs. And I'm using women to refer to anyone with eggs and ovaries right now, but I'll also would apply to transmasculine folks as well, or trans men. But the younger women are, the more successful per cycle is intrauterine insemination or IVF. Obviously, the health of each partner is a factor. We mentioned desire to be pregnant. Sometimes one partner has better insurance than the other. This shouldn't be a factor, but sometimes is. If one partner has full coverage for IVF and the other one doesn't and is not on the other partner's insurance, then that could play a role. And then oftentimes there are existing children from previous relationships, so that might be a factor as well. As far as sperm goes, there's two main types of sperm, what we call non-identified donor sperm and identified donor sperm. We used to use the term anonymous donors, but we quickly realized that nobody's anonymous anymore. So, we tell patients that you should fully expect, even if you use a non-identified donor, meaning you don't have any identifying information about the donor name, address, that type of thing, it's very likely that you or your child will find out the identity of this donor with, direct consumer genetic testing, with the internet, facial recognition software, all these kinds of things. And the fact that you get so much information from the donor profiles these days, it's really not hard sometimes to find the donor, even if they don't want to be found. But similarly, we counsel the donors as well. Do not donate unless you are comfortable with the fact that your identity may be known somewhere down the line. So non-identified donor sperm comes from a sperm bank, typically tends to be more expensive than using somebody like a friend or acquaintance. There's lower risk of any kind of custody issues down the road. You hear all these horror stories about kind of identified donors agreeing to be donors, and then something happens, couple splits up or something, and then the donor might decide they want to be a parent after all. So it can get quite messy, even though, of course, we counsel patients to have legal agreements and contracts in place. There's a higher risk of that happening if you know the person who's donating the sperm. Non-identified donors, there's also the option of what we call open ID donors. So these are donors who agree to give their identifying information to the child if the child requests it when the child is age 18 or older. So a lot of data coming out now, and similar to the adoption data, that donor-conceived children have very strong desires to know their, genetic origins, if you will. So given that a lot of sperm banks and egg banks offer this option, if the donor is agreeable to provide that information to the child, if the child requests it, not necessarily to the intended parents using the sperm, but to the child themselves. Directed or identified donors can be cheaper. If you want, the donor can have a relationship with the child. You do have to be careful. In some states, a donor would be considered an actual parent and have, parental rights and financial responsibility for that child. So it sort of varies about, depending on where you live. And a very common scenario would be you have a female same-sex couple and one of the partners has a brother that they use as a donor. That way there is some shared genetics, and that brother's sperm would be used to inseminate the partner, or if they're doing IVF, to inseminate the eggs after in vitro fertilization. I mentioned the regulation by the FDA. Because these are it's almost like organ transplant, right? You're taking tissue from a third party and planting it, if you will, into another individual. So there's a lot of regulations about how those donors need to be screened. So the FDA recommends that the sperm, for example, be quarantined for 6 months, and then that the donor be retested for HIV and all the other STIs. It's a little bit outdated recommendation, right? Um, we don't think the seroconversion window is that long anymore, but nonetheless, FDA still has this sort of regulation in place. The donor has to have a normal semen analysis. The recipients or egg donors undergo for like what we call ovarian reserve testing. So an egg donor to qualify they would need to be one, young, typically under 32 years of age, but they also need to have a normal number of eggs. And that's usually assessed with a hormone called AMH or anti-Müllerian hormone and an ultrasound to determine an antral follicle count. So the number of follicles in the ovary gives us some idea of the egg number and, is it appropriate for that person's age? Is it higher than average or lower than average, et cetera? They need to be healthy, of course, and the medical history and the family history, this is all by self-report. So that's another thing, we cancel patients about. We don't verify any of this stuff. You really are relying on the donor to disclose. And then these days we do carrier screening on the donors and often the recipients as well. And there are panels of like, in our clinic, we have a panel of 800 different genes that we test for. And it's usually, most of these are autosomal recessive, so it's usually only an issue if both the donor and the recipient carry the same disease-causing mutation. If that were the case, we would counsel the patient choose a different donor, or if they're really attached to that donor, we would recommend IVF with pre-implantation genetic testing of the embryos to screen for whatever disease might be. Is it cystic fibrosis or SMA or sickle cell or whatever it is? They have to have STI testing, of course, and a risk factor questionnaire. So one interesting thing about the risk factor questionnaire, and one of the risk factors for STIs is sex with men. And so if you are a gay male, typically you're excluded from being a non-identified sperm donor. This is similar to the blood donation situation, although they recently changed those guidelines. I think, I forget what the new regulations are, but you have to have not have had sex with men in the last year or something like that. But for sperm, they haven't gotten rid of that yet. So if you're a gay male, you can't go to a sperm bank and donate anonymously, if you will, or as a non-directed or non-identified sperm donor. Now, if you're a single woman or same-sex couple and you want to use your gay friend to be a sperm donor, that's okay. We have to tell you that the FDA, according to the FDA, this donor would be ineligible. But if you're okay with that and want to use the sperm, that's fine. So it's one of those things that we're advocating for the FDA to change that policy because obviously we think it's discriminatory. And then the ASRM recommends that both recipients and donors undergo psychoeducational counseling, and the donors, egg donors anyway, undergo testing. So sometimes you get a little pushback from patients about this meeting with the psychologist, but for the recipients is really not psychological testing or, not trying to determine will you be good parents or that kind of thing. It's really more educational about what are best practices, about how to tell the child, when to tell the child, and that type of thing. So, and we think it's important for donors as well to undergo some type of counseling to know the implications of being a donor, potential contact from, future children, the possibility of having several genetically related children out there. This is another issue that's been a problem in the field. You hear these stories of donors that are, responsible for like 100 children. most of the sperm banks now are putting limits on the number of live births that can occur from one particular donor. And this is because recognizing that it's overwhelming for the donor, first of all, if all these people were to contact him, but also for the half siblings, which, it's very easy for them to find each other. There's Facebook groups, there's donor sibling registry, and it can be overwhelming for somebody to find out that they have like 30 or 40 half siblings out there in the world. For non-identified sperm donors, the requirements are very similar. It's just that, like I said, if they're ineligible according to the FDA, the recipients can use them. They just have to be advised that, this particular donor would be ineligible. All the STI testing needs to be done in a FDA-approved lab, and it has to be done within 7 days of collecting the sperm. So that's another requirement. And for identified sperm donors, so this was non-identified sperm donors need to be eligible to donate. So if you're a gay male, cannot donate to be a non-identified sperm donor. But if you're a gay male and you want to donate to your friend, you can. You just would be ineligible, but the recipients could still use your sperm. And this, just in case you're not familiar, the way we do intrauterine insemination. So typically, a woman would track her cycles to see when she's ovulating. Usually that's done with urine ovulation predictor kits. Sometimes we use ultrasound, especially if we're using fertility medications. And when they're ovulating, they would come to the clinic. We would thaw a vial of sperm, draw it up in a little syringe. We aim for about 10 million motile sperm in each sample, and then place a speculum just as you would to perform pap smear. And then we pass the catheter through the cervix and place the sperm in the uterus at the right time. So it doesn't require any anesthesia or anything like that. And then about 2 weeks later, patient would know if they're late for their period, they would do a pregnancy test. Hopefully they're pregnant, they get their period, then they know it didn't work that cycle and they would try again. In terms of success rate, this is also important just to set expectations. So it really depends on the age of the recipient. Okay, the younger you are, the more successful it is. And even then, it's not super successful, in any given cycle. Even if you're ovulating every month and there's sperm there at the right time and the sperm looks good, unless it's a normal egg that's ovulated that month, it's not going to fertilize and implant. So success rate, even in young patients, typically, 15 to 20% or so. In older patients, especially over 40, it's less than 5% per cycle. So, it's important to set those kinds of expectations for the patients so they're not disappointed, if they don't get pregnant the first time around, and they need to know that it could take several cycles. Now, because they're paying for sperm and they're paying for inseminations, we don't give them a year necessarily. So if you're a straight couple under 35, we tell you try for a year before you even come see us because there's probably nothing wrong. But for same-sex couple or single woman, she's paying for all this stuff. We tend to accelerate the treatment. So, if they're not pregnant within 3 to 6 cycles and they're under 35, we might add fertility medication. We might, if that doesn't work for a few cycles, then we go to IVF. So everything's a little more accelerated because it's costly otherwise. And this is from another study, kind of similar. The younger you are, the more successful it is. Cumulative pregnancy rate is not bad in younger patients, but you can see as you get older, it's not super successful. And it's quite reasonable for somebody who's 40 to skip IUI altogether and go directly to IVF. Okay, IVF is not a guarantee, and the success rate is also age dependent. Success rate is higher than with IUI. Yeah, this is how we do IVF. Typically, the fertility medications are gonadotropins, and the goal is to stimulate the ovaries to produce many eggs at once, then to retrieve those eggs using transvaginal ultrasound and a little needle, and then to inseminate those eggs in the laboratory, create embryos, and then take one of those embryos and put it back in the uterus through the cervix. So you can see this is a fertilized egg. This is a blastocyst, the stage at which we basically put it back in the uterus. And again, the success rate depends on the age of the person providing the egg. Okay, switching gears a little bit to single men, same-sex male couples, they typically need both an egg donor and a gestational care. Okay, they can use sperm from one or both partners. Sometimes we split the eggs and half are fertilized with one partner and the other half with the other partner's sperm. And they can similarly use either an identified or non-identified egg donor. But the big difference, of course, is they need a gestational carrier, somebody to carry the pregnancy. And this is the part that can get really expensive. Similar requirements, the donors typically need to be young, as I said, under 32 ideally, if they're non-directed, if they're identified, a sister of a donor, one of the partners, for example, they can be older, but then you have to counsel the patient that success rate might be lower if they're older. And to be a non-identified egg donor, you have to meet all the criteria to be eligible. If you're a directed donor, you can be ineligible and still donate. But basically, you have to be healthy. You have to have negative STI testing. We do genetic carrier screening as well, do psychological testing and education. We do urine drug screen, all these things. And of course, for all patients using donor gametes, we do recommend, especially in a directed situation or identified situation, we recommend that they meet with a reproductive attorney and have a legal agreement in place just to protect the patients, protect the children, protect the donors, so everybody is clear about what the roles are of the different parties involved. One of the newer things in the last 15 years or so is the egg banks. So sperm banks have been around forever, but for egg donation in the past, we had to use fresh eggs. So you select a donor, the donor would undergo stimulation and retrieval, and those eggs would be inseminated to create embryos then and there. And all the eggs from that particular donation would belong to the intended parents. About 15 years ago, the freezing technology for eggs became so good that now you have egg banks, which are quite common. And this has several advantages. One, you could ship them all over the United States or the world even, so the donor doesn't necessarily need to travel to where the recipients are, so there's more selection. But also, they're already collected, so it can be faster. You just go online, choose a donor that has eggs frozen, and bingo, you have 6 or 12 eggs, how many you need. The downside is the success rate is a little bit lower with frozen eggs compared to fresh eggs, but it's still pretty good. So, and it's also cheaper because with fresh donation, all the eggs from one donation go to one patient or one couple. With frozen eggs, the business model is such that they might split the cohort amongst 2 recipients or 3 recipients. So maybe you just want to have one child. So maybe you don't need 15 or 20 eggs. Maybe 6 eggs is plenty. So if you do it this way, it can be a lot cheaper for the recipient. So you usually purchase like cohorts of like 6 eggs will be cheaper than having, getting all the eggs from one fresh donor cycle. Success rates are really good with egg donation because it makes sense. The donors are usually young, healthy, It's not 100%, but it's around 70% per cycle. And if you're using an identified oocyte donor or egg donor, it's going to depend on the age, of course, of the donor. Gestational carriers, they even have to go more extensive testing than donors do because, of course, they're going to carry a pregnancy. So the requirement is they need to be under 42. They have to have delivered a baby of their own to be eligible to be a gestational carrier. And I think part of the rationale here is, you need to know what you're getting into. So they want, people who have been pregnant before and delivered a baby. And of course, they have to be healthy and free of STIs and all that kind of stuff. We evaluate their uterus, make sure they can carry, etc. This is a much bigger commitment, obviously, 9 months of pregnancy. But it's also a very wonderful thing. And often just gestational carriers maintain relationships with their intended parents. So it's kind of nice. And the children sometimes have relationships as well with the gestational carriers. The laws, quite variable. In some countries, this is completely illegal, of course. So we have a lot of, what you would call medical tourism. So you have people coming to the United States to circumvent the laws in their own countries. Sometimes they run into trouble bringing those children home. So, it's can get very tricky, very messy. And even within the United States, there's various laws depending on the state that you live in. So in some states, person who delivers the baby is considered the legal mother. So then you have to, the intended parents would need to adopt that child. Obviously, we don't recommend using gestational carriers in those states. Oregon, California, Washington, New York. There's a few states that are more surrogacy friendly, I would say, where you can have an arrangement where the intended parents are on the birth certificate considered the legal parents, even though the gestational carrier delivers the baby. In the old days, they used to do what we call traditional surrogacy, where you would just inseminate a surrogate with one of the intended parents' sperm. Now that hardly anybody does that anymore. In some places, it's illegal. We all do what's called gestational surrogacy. So you need an egg donor, and a separate woman is the gestational carrier, so that the gestational carrier does not have any genetic relationship with the child, if that makes sense. And that's just, again, to prevent these, custody issues that have unfortunately happened in the past. It's just a lot clearer cut that way. So a lot of decisions, but decision is yours, what's right for you. I think LGBTQ people aren't quite as hung up on DNA as straight people are. The health of the baby is more about, the nurturing and loving environment that you provide, not necessarily, the DNA. Transgender individuals, a lot of the same things apply, but there are a few other considerations. So there's not a ton of data on transgender individuals, but there are a few surveys that would suggest that most transgender people want to have children one day. We do know that both gender affirming hormone therapy and gender affirming surgery can compromise fertility, unfortunately. So we know obvious surgery is pretty obvious, right? Like if you have an oophorectomy or an orchiectomy, and don't do any kind of fertility preservation beforehand, or a hysterectomy, then you could have challenges building a family, especially if you want to use your own gametes, or if you want to carry the pregnancy. But also with hormone therapy, so we know that if trans feminine or trans women take estrogen, that could have detrimental effects on sperm count, sperm quality, and in some cases, it's not reversible. So even if you stop the estrogen, sometimes you don't get recovery of that spermatogenesis. So ideally, patients would make sperm before they start their estrogen therapy. With testosterone therapy, it also impacts fertility, but it seems like in most cases it's reversible. So I've had several patients who've been on T for many, many years. Then they decide they want to have a child, stop the T, they start cycling again, and are able to either become pregnant or their eggs can be used for their partner to carry or just additional carrier or whatever. So the testosterone effects seem to be more reversible than the estrogen effects. Nonetheless, we still recommend if you're going to do any kind of fertility preservation, like egg banking, that you do it ideally before you start the testosterone for many reasons. Not the least of which you don't have to stop the testosterone if you want to do it in the future, if you've already done it before you start. So puberty blockers are an interesting thing. There's not a ton of data, but obviously if you've never gone through natal puberty and started puberty blockers and cross hormones before that happens, it's not entirely clear, what that looks like, right? There's not a ton of data. We think it's reversible. Like if you stop the cross hormones, if it's testosterone, estrogen, as I said, could have more permanent effects on the testes. But if you stop the testosterone and the puberty blocker, you allow natal puberty to happen, then theoretically that patient could undergo ovarian stimulation and freeze eggs or, even be inseminated and if they want to carry a pregnancy and still have a uterus. Um, so not a lot of data. We definitely need more research on this area. Both WPATH, which is the World Professional Association of Transgender Health, and the Endocrine Society all recommend that transgender patients are counseled about the option for fertility preservation, ideally before transition. Again, it's not always accessible to everybody, can be expensive, but they should at least have the conversation with somebody to know what their options are. And this is similar to young cancer patients as well. We know that chemotherapy, for example, similarly can affect fertility. And so all cancer patients, young cancer patients, before they undergo chemo, are offered a consultation with either a reproductive endocrinologist or a reproductive urologist to talk about the option of freezing sperm or freezing eggs before they undergo their treatment. But again, not a ton of data specifically in the transgender population. These are the options. So sperm banking, very usually inexpensive, not very invasive. So that, there's no excuse for somebody not to be offered. They may decide not to do it, but they definitely should be offered the opportunity to bank sperm before they start estrogen therapy. If they can't ejaculate for some reason or don't want to, then we can retrieve sperm from the testes directly. That sperm typically can only be used for IVF later and not insemination. And in prepubertal boys who are not making sperm yet, the only option for them is to freeze testicular tissue, and that's still experimental at this stage. So for trans men or trans masculine non-binary individuals, they can freeze eggs or embryos. This is the same process as the first half of the in vitro fertilization, so it does require ovarian stimulation and egg retrieval. Typically, we ask patients to stop their testosterone before they do this, although the data is, a little mixed on whether you need to do that or not. Success rate, again, number of eggs depends on the age of the person undergoing the stimulation and retrieval. You can freeze tissue, and there have been, ovarian tissue, and if somebody's having an oophorectomy, for example, you can freeze a portion of their ovary, and there have been several hundred live births now, but all these involve retransplanting the tissue back into the same individual. And most trans patients are probably not going to want their ovarian tissue transplanted back to them. So what we hope that in the future, we can actually grow mature oocytes from that tissue without having to implant it again. But that's still experimental and hasn't been successful yet. Similarly, for prepubertal girls who haven't undergone puberty yet can't do ovarian stimulation in them. So the only option really is to freeze ovarian tissue with the hope that in the future you either reimplant it or hopefully we'll have this technology of in vitro maturation. I mentioned we usually recommend stopping the hormones. Certainly in pregnancy, we don't want patients to take testosterone, of course, because that could affect the fetus. Whether or not you need to stop it to undergo stimulation, most of the time, like I said, we do recommend it, although there have been some studies that show that you can stimulate the ovaries while someone is on testosterone, but we have like basically zero data on, how does that affect egg quality or embryo quality or the babies that result from those oocytes that have been exposed to, higher levels of androgens during stimulation. We don't know. So we counsel patients that we don't know. We don't know if it's harmful. We don't know if it's just fine. There's just not data, not enough data, but we, respect patients' wishes. And there is currently research ongoing, including at our institution on this particular question. So for transgender or transmasculine individuals, trans men or transmasculine individuals, their sperm, or sorry, they can be inseminated with sperm from their partner or donor sperm if they wish to carry a pregnancy, or they can undergo IVF if they want their partner to carry or use a gestational carrier. For trans women, trans feminine individuals, their sperm can be used to either inseminate a partner with ovaries and a uterus, or their sperm can be used to generate embryos, which can then be carried by a partner or a surrogate. And then maybe in the future, some of you might have heard about uterine transplantation, which is a thing, not in trans individuals, but in cis women. So there are some women who have either undergone a hysterectomy for medical reasons or were born without a uterus. And there have been several cases now throughout the world of uterine transplantation. So either you can do it from a living donor or a deceased donor, and the uterus is transplanted into that individual. IVF is performed. The recipient typically carries the pregnancy, delivers the baby, and after they've delivered the baby, we typically remove the uterus. I shouldn't say we because I've never done it, but the programs, there's only a few programs in the world that do this. Typically that uterus is then removed again. So it's not, it's very involved. There's a several hour operation in the donor, several hour operation in the recipient, then the pregnancy, all the immunosuppressive medications, of course, because, it's from another person. And then after delivery, another surgery to remove that uterus. But in any case, in the future, we might see, and people are investigating this, whether you can do a uterine transplant into a trans female to see if they can carry a pregnancy. I think it'll be possible one day. It's probably technically a little more challenging, but I think that's something we'll see in the future. There's a few studies out there comparing cis men to cis women and their IVF success rates and ovarian stimulation results. And for the most part, there's no differences. So these are trans men who have taken androgens in the past and stopped it. They seem to get recovery of their ovarian function. In this particular study, the only difference was this group required higher doses of gonadotropins, but otherwise pretty similar outcomes. Other considerations. So the barriers to access, particularly probably relevant to this group. I mentioned cost several times. So unfortunately, infertility is not always considered a disease. So the ASRM's definition of infertility actually includes anybody who needs medical assistance to build a family. Okay, but that's not recognized everywhere. So even if it is recognized, often insurance doesn't cover it. So it really kind of depends on where you live. And if insurance doesn't cover it, cost is, can be prohibitive for some of these technologies that I talked about. And then there's, as we all know, um, discriminatory laws in across the world, but even here in the United States. So, for example, in some states where they cover IVF, it's only covered for maybe married heterosexual couples. Like that's actually a thing because gender identity and sexual orientation are not considered protected class. So it's not considered illegal per se. So there's lots of inequities that exist even here in the United States. Just to give you an idea of cost, since we've been talking about it, donor sperm, purchasing just a vial of donor sperm for one insemination could be like $1,000. So, quickly adds up if you need several tries to get pregnant. Sperm banking is about $1,000. Intrauterine insemination, about $500 each time you do it. IVF, $20,000. Egg freezing, $10,000. Egg donation, even more expensive than IVF, $30,000. And, gestational surrogacy can be upwards of $100,000 or more. So you can see that this is not going to be accessible to most patients. um, just ethical considerations, again, not a ton of data, but data we have that LGBT people, just like other people, want to have children. And the kids, even though there's not a ton of data, the data that does exist seems to suggest they're just fine, no worse off than children from non-LGBT folks. And the recommendations from at least ASRM and other professional organization is that all these patients deserve access to care. Some resources for you, and I think the slides will be available later, but these are just some organizations that have some are, professional guidelines, some are patient-facing guidelines, but a lot of really good information on some of these sites. And for transgender health, WPATH, of course, UCSF, Transgender Center of Excellence, Endocrine Society, etc. Takes a village and is really does, like, no joke. But we're here to support you, and I hope that all patients have access to care and to a supportive team. And I think we have some time for a few questions. So thank you very much again for the invitation. I'll stop sharing so that I can see some of you.
Thank you, Dr. Amato. That was so informative, and I can say that I learned quite a bit from your presentation. We are now going to save probably like the next 5 to 10 minutes for Q&A. So if you all have any burning questions for Dr. Amato, please write them in the Q&A part of Zoom. We have one from Haley, who said, "This talk has been so fascinating." I agree. And this care is so critical. I know in the current political landscape, fertility care and family building are increasingly under scrutiny. What are the major areas of advocacy that you and or ASRM have been involved in, and are there opportunities for DFA to support your work?
Yes, thank you for the question. There's a ton of things that we're involved in. The big one I mentioned is access to care. So it kind of really depends on where you live. So at the state level, at the federal level, there are various efforts to try and get infertility to be recognized as a disease and fertility treatment to be, covered by medical insurance. Other things, reproductive rights. So people think like we're infertility doctors, why do we care about abortion? But medical abortion, for example, so a lot of our patients undergoing, if they have a miscarriage, which is not uncommon in our population, we use mifepristone or, and, there are efforts, as you all know, to ban some of these procedures. So we're quite involved in reproductive rights, reproductive justice cases, or laws, in various states and at the federal level as well. We're seeing a lot of anti-trans legislation, and that impact obviously implications for fertility care as well. So we're kind of trying to fight those battles as well at various levels. particularly at state and federal level. So those are just some of the things that come to mind. But a lot of what they have in common is, protecting the physician-patient relationship, right? And not letting the government interfere with some of these decisions. So.
Thank you for that answer. I appreciate you connecting kind of those in terms of their common principles. A question that I had for you regarding kind of connecting your last piece on fertility preservation for transgender individuals. When I have talked to transgender patients about like fertility preservation, some things that I think oftentimes I don't expect when we're talking about this conversation is that like it might be a very long time before they actually like desire a family. And so the cost of banking ends up being like it accumulates over time. So I'm curious about like how how do you talk to patients about that? And then how does that like, especially because oftentimes like trans folks like often transition at a relatively young age, like how do you talk to them about like the amount of time that they might expect?
Yeah, that's a good question. I didn't mention storage fees, right? So there's a cost of banking eggs or sperm, but then it's about $1,000 a year. And that could add up, if people are storing for 10, 15, 20 years. So, I still think we should give them the opportunity and, obviously counsel them that the various costs are involved. But there's also not as much urgency, I think, in people who are on testosterone, for example, compared to people on estrogen,
I see.
or who plan to take estrogen. And the cost of sperm banking, much less than the cost of egg banking. So I think for trans women or trans feminine folks, I think, freezing sperm, relatively inexpensive, even if you include the storage fees. But because the likelihood of irreversible damage is quite high, I feel like for those patients, it's worth it. For transmasculine folks or transgender men, I've had patients who've been on T for years and then they decide at age whatever, 30 or something, 30 something, to freeze their eggs or build a family and stop their testosterone, and they have full recovery typically of their ovarian function. So I tell them, like, there's no urgency. I mean, yes, ideally cost was an issue. Freeze your eggs now, go on T, never have to come off it again. But I also tell them, hey, if you can't do it now, just know it's like not the end of the world. You may have the opportunity to do it in, later when maybe you're in a different place, you have more resources and that type of thing. So
Got it. That's a very helpful distinction between like those who start testosterone versus those who start estrogen.
yeah, of
And
course,
then,
people who are having surgery, they don't
right,
have that option either to do it later. So it's another group. Yeah.
got it. And then one final question that I had for you was I think sometimes when I talk to some LGBTQ patients about like the fact that they have to go through, or maybe have to is perhaps not the right word, but oftentimes there needs to be medical intervention to build a family, that sometimes that can feel a little bit less like, or it feels a little bit more sterile or a little bit more clinical than what they're hoping for. And so I'm curious about like ways you try to help your LGBTQ patients make this process feel a little bit less like that.
Yeah, that's a good question. So there are some patients who do like home inseminations, for example, and that's quite common in the LGBT community with all the caveats, right? Like, not the same sort of one, the success rates are a little bit lower because you're not doing intrauterine insemination. Typically, you're doing intravaginal or intracervical, maybe. Um, Oftentimes they don't do all the recommended testing, so it can be a little less safe. But for many patients, it's the only option because, I mean, one, they prefer it, or two, it's less expensive, or both, right? Um, I mean, we try, I don't know what we do specifically. I think, for LGBT folks and or for straight people, uh, um, cis people, like, coming into the clinic, it's not it's going to feel medical to some extent, but we try to make it a welcoming environment. We certainly try and make it an inclusive environment. There's literature for various types of families and normalize it as much as possible. We have, collection rooms with videos, or these days people can bring their own phone. But yeah, I mean, we do some things, but it's always going to feel a little bit clinical.
Got it. Thank you for that very thoughtful answer. Okay, with a couple minutes to spare, I'm going to close this out. So again, thank you so much, Dr. Amato, for coming and for giving this wonderful presentation and for promoting such thought-provoking discussion. So thankful that you were able to join us. Before everybody leaves, here are a couple of quick reminders. If you are interested in issues related to LGBTQ health, health advocacy, or health justice and equity in general, please consider joining us over at the Health Justice and Equity Committee. The link to join is on the DFA website. Please watch out for additional opportunities to provide input on future policy issues. And then for those who are paid sustaining members of DFA, just a reminder, complete the survey for 1 credit of CME for attending this session. That is about it. Again, this recording, as well as any slides, will be available for folks to access on the DFA website. And thank you so much for joining us tonight. Have a great rest of your night, y'all.